This video will cover information on high-risk antepartum. We don't use the term high risk with patients and families. However, when you're looking at the literature, particularly the medical literature, those are sort of how it's classified, or that's what the terminology is. But I would not use that terminology with a family or a patient. And there's some information in your slides about social determinants of health and how a high-risk pregnancy does impact a person and family. So please do read through those slides independently. The first topic that we're going to talk about is antenatal bleeding. Spotting or bleeding can happen earlier in pregnancy for a variety of reasons. However, it's considered to be antepartum bleeding after the 20th week of pregnancy. Sometimes people will have bleeding if they have a spontaneous abortion or miscarriage. Implantation bleeding can happen as well. However, after the 20th week, when it's kind of at that closer to the age of viability, that's when it's considered to be true antenatal bleeding. Possible causes of antenatal bleeding include placenta previa and placental abruption, which we're going to talk about next. Placenta previa occurs when the placenta is implanted in the lower uterine segment rather than the upper part of the uterus. The blastocysts actually implant in the lower uterine segment in this situation, often in the anterior versus the posterior, and it's over or close to or covering that cervical os. So you can imagine we were talking about in the labor class about effacement and dilation, and you can imagine that if there's a placenta there and all of those that vasculature and vessels, then you're going to have antenatal bleeding. So typically what we would do is we diagnose this by a transvaginal ultrasound. We make sure that the transvaginal ultrasound wand or probe is not inserted too far because you don't want to actually be pushing on the placenta itself, but that is how it's diagnosed. So the SOGC does have a guideline on that from 2020. The other thing that can be helpful too is if it's kind of in a different spot, the placenta, they'll actually sometimes look for that before a cesarean birth to make sure that they're not cutting right near where the actual placenta is as well. So different types, I'm going to animate this on your screen. You can see this is a nice picture of a complete, partial, low-lying, and then a normal placenta. Marginal placenta, partial and complete, typically would require a cesarean birth. Sometimes even a low-lying placenta, they'll decide to do a cesarean birth just because it can be more risky, especially if they've had previous cesarean births. When we think about risk factors for placenta previa, there's a few things that might clue us in. Previous cesarean birth, previous previa, being older than 35 years old. Smoking is a risk factor. It's based on the number of years, not the quantity of cigarettes smoked. Uterine abnormalities, short intervals between pregnancies, previous miscarriages or abortions may increase the risk slightly as well, but we're really not sure why that blastocyst implants lower in the uterine segment. Clinical signs and symptoms, bleeding is painless, and you may feel a soft uterus on palpation rather than feeling the baby's body because you're actually palpating where the placenta is. Usually with placental previa and when you have that bleeding, early on, the fetal heart rate's there and it's normal. However, as there's more blood loss, shock and anemia will correspond, of course, with the amount of blood lost. With these patients, there is an increased risk of postpartum hemorrhage, of course, and there may also be abnormalities of the placenta that we're concerned with and cord insertion abnormalities as well. Interventions, as I mentioned, would be to have a cesarean birth and to anticipate, lots of health teaching with these families. If there is any bleeding, they need to come in. If they have signs and symptoms of labor, that early labor, we want them to come in too because we want to be able to get them to section before they start laboring, before we have that effacement and dilation. And if you did have a patient come in, and I have seen this before, that people have a previa, they have a planned section for 39 weeks, and they go into labor before 39 weeks. So we want to be ready for those patients. And of course, it's IV access, and that would be considered an emergency cesarean birth. Depending on the amount of bleeding, we don't want them to continue to labor with a previa. If you love patho like I do, you can watch this Khan Academy video. It's kind of cool. It shows what actually happens and explains some of the vascular changes that are happening. It's not necessary for this class, but I think it's interesting to sort of know what's actually happening in the body. So that is in your slides. Now we're going to talk about placental abruption, or abruptio placentae is sometimes what you hear it called. This is a premature separation of a normally implanted placenta from the uterine wall after the 20th week of pregnancy. And so what's actually actually happening, you can see the partial abruption in the first picture. In the A picture, there's a concealed hemorrhage there. So we're not actually having bleeding. So this might be a situation where you see, the baby's fetal heart rate changing. You'll see a very firm uterus. You'll have someone that is saying that it's painful bleeding, but you may not actually see the blood. You can see in B, there's a partial abruption with a parent hemorrhage. So that one is actually moving away from the uterine wall and there's bleeding that's happening. A complete abruption is C, and that's where you see actually the complete separation of that placenta after the 20th week, and it's a concealed hemorrhage. So those are the different types that you'll see with placental abruption. This type of antenatal bleeding is a significant cause of bleeding in the third trimester. It's actually one of the most common causes of fetal death, so in utero, and it happens in about 1% of pregnancies across the world. The fetal mortality rate for placental abruption is anywhere from 20 to 40%, depending on the extent. So you can see there's different types, partial and complete. And of course, when it's an apparent hemorrhage, we're able to sort of assess it and know that it's happening a little bit sooner. We don't know why this happens. They think that maybe there's some degenerative changes in the maternal arterioles, and there's thrombosis and degeneration of the decidua, and then you end up with a rupture of vessels, and then it starts to pull away. Of course, the baby's fetal blood supply is compromised, and you'll see fetal distress. There are different classifications. So with mild, the grade 1, it's usually less than 500 mils of bleeding, which is still pretty significant. Marginal separation, with that one, it's about 10 to 20%. You'll see it, you'll still feel that tender uterus. The patient will say that their uterus is tender, but you don't see any like blood clotting changes, nothing going on with coagulation at that point, and then sort of not as much fetal distress. As you go further into moderate grade 2, you're having about 1,000 to 1,500 mils, a more moderate separation. You'll have more continuous abdominal pain that your patient is stating they have, and mild shock happens. With severe, you'll see greater than 1,500 mils of blood loss, and again, the baby is not going to be happy. There's profound shock. They have really severe abdominal pain, and this can also cause DIC as well, so disseminated intravascular coagulopathy. So this is something that we need to be assessing for, and knowing the difference between previa, painless bleeding, and abruption, which is painful bleeding, is really important to differentiate, because you could be even working like an emerge and have people come in with something like this. Risk factors for this, again, we don't really know. Most of the time it's idiopathic, meaning we don't know why it happens. However, there are some risk factors in the literature: advanced maternal age, hypertension, substance use, including cocaine, tobacco and alcohol use, the baby having a short cord, any abdominal trauma, polyhydramnios, which is too much amniotic fluid, preterm premature rupture of the membranes, increased parity. So the more babies people have, the more this seems to happen. But again, it's not a lot of pregnancies that have this. It's about 1%, but the implications can be severe in terms of, fetal death and hemorrhage. The other thing that happens too with trauma, sometimes if there was like a motor vehicle accident, sometimes a hematoma will occur and then it heals a little bit and then it rebleeds again and then it causes this ongoing separation. So we want to make sure that we're assessing this. Onset may be sudden. The goal is to treat the cause. So sometimes visible vaginal bleeding can be misleading because it can be concealed with this. You are, of course, going to be assessing for the color and amount of bleeding, uterine tenderness or rigidity. There's pain in the abdomen, and it may also be in the back. It can be sudden, sharp, and severe. Sometimes the concealed blood can actually cause contractions, so you might feel all of a sudden like a rigid abdomen when you're palpating the uterus. Keep in mind that the maternal vital signs may not change initially either, because they have so much increased blood volume, increased cardiac output. So we don't always see signs of hemorrhage in pregnancy and postpartum as early as we would in a non-pregnant patient. Later on, of course, you'll see their blood pressure drop, they're hypotensive, they're tachycardic, they have pallor, they have decreased urinary output, they feel thirsty, they have irregular respirations. For fetal health surveillance, usually there's no resting of the contraction, so it's just like that what we saw in class the other day when the pressure doesn't go down at the bottom of a contraction, they may have those late or variable decelerations. Third term and it's severe, we would deliver this baby. They would have a cesarean birth immediately. And again, I've looked after babies after a placental abruption in the NICU as well. And sometimes they are hypovolemic. And so we'll be doing, blood transfusions, fluid replacement, and depending on the severity, potentially intensive care for these patients as well. So let's do a quiz question. Ms. Pope is 21 years old and presents to the clinic at 35 weeks gestation. There's no pain and no contractions. What information should the nurse know about bleeding late in pregnancy? So I'll give you a minute to read through each of those. Is it A, soft uterus and painless bright red bleeding are signs of abruptio placentae? B, the complications of antepartum hemorrhage are hypovolemic shock, anemia, and preterm birth. C, the extent of hypovolemic shock is related to the amount of visible blood loss in abruptio placentae. Or D, placenta previa should usually be found on a routine vaginal exam. So which one do you think is correct? Okay, so let's look at A first. A soft uterus and painless bright red bleeding are signs of abruptio placentae. No, those are signs of placenta previa. B is correct. Those are complications that the nurse should anticipate. So we're thinking IV access, preparing for delivery, an emergency C-section. And then C is not correct because placental abruption can actually conceal blood as it's pulling away from the uterine wall. And then D, hopefully we're not finding a previa on routine vaginal exam. It should have already been identified in ultrasound, and it would be, and a transvaginal ultrasound is the type of ultrasound we'd use. So that concludes the antenatal bleeding lecture. Please do reach out to me if you have any questions. Thank you.